my name is Helen Lee, and I'm a senior at UC Berkeley studying molecular environmental biology. Today, I'll be talking about the lack of research among people of color and the various intersectionalities that play into this. First, let's explore. We know about the lack of research among people of color. We know how harmful it is, but how detrimental is it? How does the lack of research really affect people of color? Although I won't be able to cover this broad, vast topic, I will provide some specific examples as to how the lack of research among people of color prevails to this day. Before we delve into this topic, here's a breakdown of what I'll be discussing today. People of color and the EGFR, estimated glomerular filtration rate, people of color and the model minority myth, and the conclusion. First, let's understand implicit bias. There are many forms of biases. Implicit bias, in fancy terms, is a lack of internal validity or incorrect assessment of the association between an exposure and an effect in the target population in which a statistic estimated as an expectation does not equal the true value. In more general terms, implicit bias describes when we have attitudes towards people or associate stereotypes with them without our conscious knowledge. Implicit bias manifests itself everywhere. In schools, workplaces, criminal justice systems, and in the healthcare system. It can also help to explain microaggressions. Microaggression is a term used for commonplace daily verbal, behavioral, or environmental slights, whether intentional or unintentional, that communicate hostile, derogatory, or negative attitudes towards stigmatized, culturally marginalized groups. Here is a classic example of implicit bias. You see a Black man walking in your direction at night. You cross the street because you associate the Black man with danger and or violence. This is a manifestation of implicit bias playing into our daily lives. How can this be harmful in a context of healthcare? Let's dive back into this. I'm going to delve into people of color and the EGFR, or the estimated glomerular filtration rate. What is EGFR to begin with? EGFR is a mathematical way to estimate how well your kidneys are working from the amount of creatinine in the blood. Everyone has different levels of creatinine in the blood. This is a waste product that comes from the normal wear and tear on your body's muscles, and also from the foods you eat. Everyone has creatinine in their bloodstream, and it may be affected by factors such as age, sex, and body weight. EGFR is one of the key tests for diagnosing kidney disease. So, what does race have to do with this? Race was originally included in EGFR calculations because clinical trials demonstrated that people who self-identify as Black or African American can have, on average, higher levels of creatinine in the blood. So, higher creatinine means higher EGFR, which indicates a better kidney function. This meant that African American individuals were assumed to have better kidney function just based on their race. Therefore, EGFR lab reports only include African American and non-African American results. Let's think about this. Why is this problematic? There has been increasing recognition that this may lead to inequitable and delayed care. This also raises the question of, what about all the other people? The other people of color, multiracial individuals, how are these people's EGFR evaluated? This is a great question, and many professionals are still struggling to come up with an answer. As to this can lead to higher risk of flawed clinical care, overdiagnosis, or underdiagnosis. The president of the National Kidney Foundation, Paul Palevsky, states that the use of race in clinical algorithm normalizes and reinforces misconceptions of racial determinants of health and disease. We must move beyond this if we are to address the racism and racial disparities that impede the care of people with kidney disease. In fact, there are active efforts going on to change the status quo. Next, I'll be talking about people of color and the model minority stereotype. According to the scientific data presented, it seems to be the common knowledge that Asians in the United States are in good standing. But are they really? What are some of the alarming limitations that are not more widely discussed among Asians in the United States? One idea to note is a model minority stereotype. The model minority stereotype emphasizes the idea that Asian Americans are more successful in comparison to other minority groups. It perpetuates the idea that every Asian American is intelligent, hardworking, wealthy, self-reliant, submissive, along with other distinct characteristics. So why is this harmful in the first place? First of all, it drives a wedge between different disadvantaged groups. The term model minority is misleading, and statistics often do not reflect the expectation of the Asian American stereotype. Asian Americans in the US encompass a very large, diverse group. This terminology groups all these diverse groups into one biased category. Asian American, Native Hawaiian, Pacific Islander population represent more than 50 countries or cultures of origin and 100 different languages. And they are in fact the fastest growing racial or ethnic group in the United States. According to the chart on the right, you can see that the Asian Americans break into many different groups: East Asian, Southeast Asians, South Asians, Pacific Islanders, and within these groups are various subgroups. This helps to give a visual representation of the diverse groups that encompass the label of Asian Americans. But despite the diversity of Asian Americans, the data for the Asian American, Native Hawaiian, Pacific Islander populations are typically grouped together. This can conflate or inflate the magnitude of health and health outcomes. This can be harmful because under the label of Asian Americans are people of vastly different backgrounds and experiences. For example, Indians have a high median household income and education, but Cambodians have a much lower income and education. And on this note of highlighting the diversity of Asian Americans, here is an alarming statistic. 0.17% of the overall NIH budget was allocated to 529 Asian American, Native Hawaiian, and Pacific Islander related clinical research groups over 2 decades. The lack of research among Asian Americans is evident. The number and amount of Asian American only grants has increased, but they still account for only 1/5 of 1% of NIH's clinical research budget. The funding allocated to the total Asian American research remained less than 0.5% for both the overall NIH budget and clinical research budget. Why is this harmful? The lack of research and disparate funding of health research can result in worsening health disparities and health outcomes for Asian American populations. Asian American, Native Hawaiian, and Pacific Islander groups continue to be grouped into one group till this day. This leads to unequal representation of the diverse Asian American groups, as discussed before. For example, in aggregate, Asian American adults' rates of liver cancer incidence and mortality are double those of non-Hispanic white adults. However, when data are disaggregated, liver cancer incidence is 7 times higher and 9 times higher for Laotian men and women, respectively, compared with non-Hispanic white adults. Therefore, it's crucial to understand the complexities of the different groups. This can be the determinant factor in eliminating or worsening health disparities. Also, another equally important point is that treating Asian American populations as one group assumes that the cultural beliefs and experience are the same, which can potentially influence and prolong misleading clinician stereotypes and unconscious biases about patients. There are many factors such as immigration, English language proficiency, health and digital literacy, preferences of clinical care and treatment that are vastly different among Asian American subgroups. Inclusion for these underrepresented population allows for more useful data to reveal the health status of Asian American subgroups and helps to dispel the model minority stereotype. Now, so what? Why is highlighting the lack of research important? Highlighting the gaps in clinical and scientific research goes so far in improving the health outcomes for people of color. This can improve causal inference by conceptualizing racism, not race, as a cause of health inequities between racialized social groups. It can improve the evidence base for actions, policies, and interventions that will both improve population health and reduce health inequities. It can increase critical self-awareness about how one's societal and historical context shapes science and who does it. It also has implications for public health practice. I'm proud to say that we are working towards change. There are implicit bias training guides to promote awareness of implicit bias among primary care physicians and their practice teams. These provide resources for instructing healthcare professionals on how to reduce this negative impact on patients. There are also larger efforts to include the people of color within research, but this is still an ongoing process. What I've discussed today barely scratches the surface on the topic of lack of research among people of color. I hope that this video will prompt further discussions about this topic among your friends, families, colleagues, and teachers. Thank you.